Dr. Anil Sharma would be taking us through periprocedural coronary dissection, perforation, and rupture. So Dr. Anil Sharma is the professor and head department of cardiology, Bombay Hospital. And he has worked with the prestigious Mount Sinai Hospital. And also he has a great experience regarding the procedures since last 27 years. So over to you, sir.
Thank you and good evening all. Yeah, changing. So why complications occurs? Most of the time, the complications occur because we do not respect the artery. We do not respect the lesion. You know the Lord Rama, even in spite of the being avatar of Vishnu, he requested the sea to give path to reach the Sri Lanka. Though he did not give it, there were different reasons. He explained that I cannot accept your request because you are a Lord. So you have to threaten me, then only I will give. And I will tell you how to make this thing nil and null. But the practice is that you should give respect. I can do it. Only I can do it. I can do anything, anywhere. I'll just do in 2 minutes. I need no other partner and blah, blah, blah. So I'm ready now. So after your brown ward and all clinical cardiologists, when you appear your DM, after the DM exam, in the next 1 year, I request you all to finish 2 books. One is the Manual of PCI by Dr. Brilakis, and another is practical textbook by Dr. Ilyas Hanna, ELIASHANNA. These 2 books, if you read and that you keep it in the brain, I think the chances of all this complication will be very less. It will not be zero. Because if you say, somebody says, I will not cause any, I have not done any complication, there are only 2 differential diagnoses. One, he has not done the procedure. And second, he is a liar. So these are the possible complications. Out of these 2, I'm going to talk about this coronary dissections and perforations. Dissections are not always good. It is very common. And we can see by the National Heart Lung Blood Institution classification, type A, B, C, D, E, F. In morning, we discussed the type A and B are not very important, rather may be good. As I was telling you that during my interaction with Dr. Antonio Colombia last CSI meeting, I was chairing session with him. He said A, B are good because it allow things to reach inside, like fracture of the calcium. So dissections A, B is good. C, depending on your experience, you can leave it, but D, E, and F are not good. So A is luminal haziness, B, linear dissection, C, extraluminal contrast, D, spiral, E, dissection with persistent filling defect, and D, the F is the total obstruction. So what are the causes? One is the spontaneous coronary artery dissection is CAD, which is more common in the younger woman, is less than 50. I'm not going to discuss about this. Acute MI, we all know. Again, this is spontaneous, but it is different. So SCAD is non-traumatic and non-iatrogenic. So third is the iatrogenic. The commonest is injection with dampened pressure. Ventriculation means it is the change in the diastole, while in dampened pressure means it is change in the systole and diastole both. So what are the causes? Osteal disease or non-coaxial guide, which may be too deep inside or maybe big, or maybe side hole. The side hole is dangerous. It gives you false protection because you are seeing the aorta pressure while you are injecting with the arteries, which is wedging the artery. So side hole dive is maybe one of the biggest reasons for dissections. Then vigorous injections, extensive and aggressive guide manipulations, anomalous origin, couple of cases I will show you, tortuous and calcified lesions. These has to be handled very carefully. So that can be caused by guide extension, I said in morning also, guide extension should never be put directly on the wire. First wire, then put the balloon, and over the balloon slowly push the guide catheter extension. It may be balloon, it may be stent related, or maybe after stent it is maybe because we are in hurry to finish it with the direct stenting or with the partial ballooning, we do stenting. Then very difficult under expanded or malposition stents are there. Or vigorous, sometime patient take deep vigorous inspiration, maybe coughing, that can cause sometime dissections. How to prevent? Never ever inject with the dampened pressure. Be gentle, give respect. Size imaging may be helpful, but not necessary in all the patients. So what is the diameter? Where we have supposed to put the stent to see proper preparing. It's 3.5 artery, big lesion, just doing ballooning with the 2.5 or 3 is not enough. Try to finish 1:1 artery ballooning. Prepare the bed properly. Incomplete bed preparation, stent does not open, then you go for aggressive ballooning. I've written a letter in 2023 textbook of CSI. There is a article of mine. Dr. Anushri is here. She is my co-author in that article. You can find all these details how to tackle with this partially difficult to cross lesion and difficult to dilate lesions. And all dissections are not bad. You can see here. This happens, pressure is dampened, both systole and diastole are low, but operator is in hurry. So no hurry, no worry, no curry. So somehow this could be managed well with the stenting. This is a 60-year male diabetic hypertension, ACS, LV of 45%, angiogram, syntax score 28, RC also lesion. Dr. Anushri Shankar both are here. One was on the right side, another was on the left side. I decided ultimately to do the 3 stents, one in the sarcoem, one in the LAD proximal here. You can see here 2 lesions, and third RC, I want to finish it. So I did this reasonably well, just edited the sheets, very happy. I was thinking about this lesion. Yeah, here you can see. Just a you see here the circle. Yeah. Just proximal to that stent, something. So I said everything seems to be okay. Before moving to the RCA, let me check that whether I should put one more stent. I'm missing it or not. I was thinking about the proximal LAD, and I took one shoot only. Oh, what happened? Oh, I said, Shankar. And then Shankar came. What happened, sir? I said, I'm not remembering you. I'm remembering the Lord Shankar. So that you can see the guide-induced big dissection. Now, one thing is very important, whether how the patient is hemodynamically stable. Definitely mechanical supports are required, maybe fluids, inotropics, and supports. Then if wire is inside or not, don't be panic. You have supposed to just withdraw the guide, but don't remove it, because the panic is the most important thing. You remove the guide and wire comes out. Try to keep wire there. If wire is there, things are still not good, as Dr. Sandeep already said, that just relax and try to fix it there only. But these are the only cases, like Dr. Sandeep said, that fix distal stent before. This is the only place where I would like to finish the proximal stent. Though this is, I've already done the distal things, but at the starting of procedure, suppose this would have been occurred. So I am supposed to fix the first proximal lesion, because then what to do? Disengage the catheter, just slightly keep the catheter, don't inject, because injecting can worsen this thing. How to confirm that I am in true lumen? Wire advances easily, no knuckling, it is not a spiral movement, it goes into the side branch, it does not cause any extra ectopic, or it can be confirmed by the contralateral shoot, or imaging can be confirmatory. Just stenting, don't waste your time. Just whatever size your eye says, or imaging if possible. Otherwise, just stent it, and then you can plan it and overdilate later on. If not, then keep prolonged ballooning. If it does not work, then surgery is the answer. So I did this 436 stent. Then I did this. Then I planned for the RCA next day. This stent again, Shankar was with me. And this is now perforation of the femoral artery. Somehow with the compression, it was this patient, I could say. Another patient, just a guide-induced dissection. You can see with the imaging. Again, we'll see. Again, one of the speakers said about the OCT, less than 60 degree. It is not the percentage, less than 60 degree. Up to 2 millimeter is small, less than 60 degree small. And if it is not going to the media, you can leave it. But otherwise, if it is more than 60 degree, more than 3 millimeter or more, or it is going to the media, then we should fix it. It was fixed. Another stent, the guide induced. Rapidly stent was put, but the stent was not very well opposed. And later on, you can say right side, it was very well fixed later on with the full expansion, this one here. So if wire is out, then what to do? Then try to rewire it. Try to take a wire guide which does not go deep like XB or something. Just take the JL or something outside. I call it an outstanding guide and outstanding wiring by outstanding operator. Then try the CTO techniques. Though this technique also can work some time to aspirate from the false lumen. So this is the published in the JAC by Dr. Martins. RCA, ballooning done, dissection is normal dissection. But while this is tortuous artery, while putting the stent, he brought all the thing comes out. Then he tried, could not do anything, went to the false lumen. Then again, he used the various CTO technology, the string ray, and he could do it successfully. Another thing is, while this is the RCO CTO via the LED septals. Now you can see here, big dissection in the proximal LED. So while anywhere you're trying for the collaterals like CTO operation, from the LED septals, another wire is better to keep it to prevent like a stepney for safety. This again, I said that stent edge dissection. This is again less than 60 degree. It is length is now 3.4 millimeter. Whether it is deep muscular media or not, you can see here. This is white arrow, 1 millimeter, not going to the media, while the yellow, here you can see this is reaching to the media, and this is 4 millimeter length. So this has to be fixed. Another stent, this can be left alone. So then imaging can be very, very useful. This was the stenting done. Patient was asymptomatic by some other center, then shifted to the, then again that after the finishing this thing, this is the final shoot by the imaging. So it was done very well. So this is how it looks. Again, superficial things seen better by OCT. So you will do OCT or IVAS? In this case, dissection. OCT is better, but can be disaster because by injecting forcefully, you can increase the dissections. Aortocoronary dissection class 1 involves the cusp. Class 2, less than 40 millimeter from the cusp. And class 3 is usually disaster. These are some of the example. You can see the cuspal, aortic cuspal. It is very common during the one I showed you at the left main. This is about the right main. And this is the left alone. And even after the 3 months, this was persisting, but patient was stable. Now coming back to the other perforation complication, that is a perforation. Perforations are usually bad, unlike the dissections. Alice criteria, severity, class 1, crater extending outside the lumen in absence of dissection. Because if it's a dissection, it cannot be called as perforation. Class 2, pericardial or myocardial brush with less than the size of the exit hole, less than 1 millimeter. Class 3, the hole size is more than 1 millimeter. And if it is a spilling to the cavity, it is class 3 CES. 75% by location are in the proximal artery. Then there can be other places like distal wire. This is commonly seen in the septals, diagonals, and then RV branches. And then there are various techniques. And this is those who are doing CTO, they understand this can be septal perforations or epicardial perforations. How to prevent? About the oversized stent and balloons, imaging may be benefit. So proper sizing, as I said, be gentle. In dissection, same thing. Avoid very high pressure balloon inflation. Always confirm guide wire position within the vessel architecture. This can be disaster. We're putting the wire in CTO or something very difficult lesion, and we take a small balloon it, and we find the distal portion was outside the vessel. It can perforate, can lead to the rupture of the artery. So make sure, already I told how to confirm multiple techniques. I've already shown how to confirm the distal true lumen. pay attention to the distal guide wire position. As I said, India is neither Mumbai, nor Delhi, nor Hyderabad. India is from Kashmir to Kanyakumari. In the medical science, Kashmir to Kanyakumari means you should see the guide, not the lesion in the proximal vessel or distal vessel, and distal tip of the wire. If you are not able to do so, dealing with some difficult thing, you should have one assistant or something fellow with you, like I have. Now they are about to leave me, Anushri and Shankar. She is smiling. But you should have, not necessarily your senior colleague, even your junior colleague, because your patient myocardium may be stunned, but your cerebrum is stunned. So take the help of the other cerebrum. Using the trapping technique to change the wires. And if once the wire finishes or balloon finishes job, just change it. Difficult lesion, you are using that whisper or whatever, XT or Confluence or any wire. Job is done. At the earliest, change it. And always distal tip of the wire and guide should be in your visual field. There are the 4 basic things described by the Dr. Bilakis. Inflate the balloon to occlude the vessel. See the hemodynamic assessment. Ask for the immediate echo. Ask for the more assistant or more your colleague, senior, junior, whoever here. It is a teamwork. Just believe in we. Don't say anything me, because who does me? Bakra and cut jata hai. So don't do anything me. It is we wins. So fluid, vasopressor, or anything maybe support may be there. Pericentesis, which can be known by the pressure tracings or maybe echo, and give it call to the surgeon. Then thing is, if we can put covered wire, covered stent, that is the best thing. But sometimes tortuous arteries and calcified lesion you are not able to do. Then you can do the prolonged balloon inflation. If it is not possible, then you can try to do the reversal of the heparin. But before the reversal of this anticoagulation, make sure that all guide wires are out, because this heparin we use to prevent the coagulation because of these devices. Keeping the guide and wire there and in reversal can lead to the disaster thrombus formation. And again, if it is a distal vessel perforation, still you can use the embolization, fat coils, or many other things are there. Like there are even covered stents are of different kinds of there. Then they fail, then same thing can be applied. So this is the technique. Like you just balloon it. Meanwhile, your brain, allow your brain to settle down. Let the other help come. Like this patient, RCA with ballooning, it settled with the ballooning only. Here you can see here, what is this? Pulsus paradoxus. It is just not a question to be asked in the Viva. Pulsus paradoxus is the thing to be seen when pericardial tamponade is there. And there you can see, and it is not the amount of the blood, it is the rapidity with which Bell's falls. So then you can see balloon, important semi-compliant balloon, less than 10 atmosphere, more than 10 minutes. But then what will happen to the distal artery? It can cause another infarct. So what thing is, just put a small wire, microcatheter, just side to the balloon. So inflate the balloon, immediately put another wire, put another microcatheter, deflate the balloon, and then push the microcatheter and inflate it again. So distal perfusion can be done. The distal perfusion balloons are available, may not be available in all the cath labs. These are the FDA approved stents. We have at Bombay Hospital Graftmaster, but it's difficult to put because it is a two stents. But in people, this papyrus stents are easy to. It can be even 5 or 6 French. It is easy. There are other covered stents like on vein. Vein can be mounted on the stent, and there are in Chinese. There are new terms. They are just in emergency. They use the tegaderm. They roll tegaderm over the stent, and that it can used as a covered stent. Some papers are there, though it is not approved still, but Chinese are using it. So covered stent, it can be 2 ways. If it is a big guide like 8 French, same guide, you can put the another wire, and you can put the covered stent through it. You can see here, inflate the balloon, put another wire, deflate balloon, put wire, again inflate balloon. Take the covered stent till here, deflate the balloon temporarily, again put this thing, withdraw the wire and covered stent and put it there. Another can be 2 guide technique, that is also known as ping pong guide technique. because your guide is 5 or 6 French or 7 French. It cannot accommodate two things, particularly graft master. So you have to take another guide, one guide that put it just outside, let this be their balloon there, inflate the balloon, put the another guide, deflate balloon quickly, wire it, again inflate it. Take the now covered stent till this portion. You can see here in this slide, if you can able to see. So these are the different techniques by which you can put this covered stent. If it does not go, then definitely prolonged ballooning and then surgeon or maybe reversal can be helpful. Then small vessel perforation, balloon inflation, or maybe fat or coil embolization can be there. This is what I was saying about the Kashmir. You should say the ostium of the left main or artery, and there it is the lesion. Always you should behave like a Arjuna, Chidiya ki aankh, but at least somebody should see about the Kashmir and then Kanyakumari. You can see where the Kanyakumari is going, and you can see here these small perforations are there. And this is again wire going into this RV branch, but again with the ballooning, this was enough. Try to put the cover stent. You can see cover stent is here. It cannot go here. So just prolonging. Fortunately, it worked. So fat and coil embolization. Coil embolization is cheaper, better. It is you can see it, you can control. But fat is easy. Just put a cut, just crush it, and you just take this fat, and you can. But because you don't see it, so you can soak it into the dye, and you can use all these local techniques. But it is a cheap. In emergency, anything is good. So then again, these are the coils are there. This is the Prograde. It is a bigger one, 2.5 French, and another one is the fine cross, that is a 1.8 Frenches is there. So it is easy to put. So this again, same like covered stent. I said, say, if it is 8 French, usually we don't have. So we can put the another guide, and you can do same thing, ballooning, inflating, deflating using other wire. Yeah, you can see here, putting all this material, fat or coil, whatever it is. Or if it does not work, then you can put this, close this side branch by putting the covered stent into the main artery. So these are the various techniques. This patient, spontaneous resolution occur after the 3 months. So heparin reversal is there, but most important thing is do not reverse heparin until unless you remove all the balloons and guides. So thank you very much, my dear friends. Simplifying a complex lesion is an art. Avoiding complexifying a simple lesion is a bigger art. Don't lose your cool. It is a teamwork. Sorry for writing. It is a teamwork. Be fast, be smart, and protect the heart and life. Effort plus wrong tool, no results. So right tools, right size catheters, right technique. You have two choices. Think and then act, or otherwise you just act and keep on thinking what to do or what I have done. Thank you.